Good afternoon and welcome. Thank you for joining us for today's webinar, which is entitled Exploring the New National Social Care Quality Measures. How do we define and measure social needs and high quality social care? This webinar is presented by State Health and Value Strategies and Social Interventions Research and Evaluation Network. SHVS is a grantee of the Robert Wood Johnson Foundation, which assists states in their efforts to transform health and healthcare by providing technical assistance to state officials. And I'm Heather Howard, director of SHVS, which is housed at the Princeton University School of Public and International Affairs. And as I mentioned, we're thrilled that today's webinar is co-presented by Social Interventions Research and Evaluation Network, what many of you know as SIREN. SIREN is a fellow RWJF grantee and is housed at the Center for Health and Community at the University of California, San Francisco. Today's webinar will be facilitated by Dr. Laura Gottlieb, who is the co-director of SIREN. Now, before we get started, I wanted to review a few housekeeping matters. All participant lines are muted, but we're looking forward to the question and answer. And so if you have questions throughout the webinar, we're going to get to questions at the end, but if you have questions at any point in the webinar, please feel free to use the Q&A box. We'll be monitoring them during the presentation, and we'll get to as many as we can before the end of the hour. So at any point when a question occurs to you, jot it into the Q&A box. And after the webinar, the slide deck and a recording will be available on our website, www.shvs.org, and also posted on the SIREN website. So you'll be able to come back and share it with colleagues. So welcome again, and I'm delighted to turn it over to my friend Laura for today's agenda. Laura, take it away.
Thank you, Sarah. So welcome, everyone. I am Laura from the UCSF SIREN team. Many thanks to you, Heather, for kicking things off. I'm truly delighted to be doing this in partnership with State Health and Value Strategies, and I want to just offer that entire team my deep appreciation for their vision and leadership in the state Medicaid space. I also will add, I'm just really pleased that we have so many participants today and so many people who have actually written to us and said, I really want the recording, or if I can't go. This is clearly a topic that is garnering a lot of attention across the country, and I'm just really glad to have today's forum to dive in a little bit. So quick review of our agenda. I'm going to start with a brief intro of where we are in the field of social and medical care integration, just to level set and tee up the conversation. And then I will introduce our terrific lineup of speakers. They'll help to do some landscaping for us about the field of social and medical care integration, what some of the new social care quality measures look like and what they're intended to do. And then the entire second half of today's conversation is reserved for discussion. We're going to talk about why there's so much variation across these different measures and the implications of that variation. We'll talk about how we might strengthen the current measures and better harmonize them over time. And as Heather mentioned, we welcome you to send questions our way using the Q&A function of the platform. And many thanks to Becky for handling some of those questions already. So why are we having this conversation today? As I'm sure all of you know, for a long time, the evidence has been accumulating to show that socioeconomic adversity can negatively influence health. And in the last decade, we've seen so much enthusiasm around exploring the appropriate and effective roles for the healthcare sector in that space. So those of you who've seen me present before may have seen a version of this slide. I like to use it to underscore that there are a lot of healthcare innovators who have been working in this area of integrated social and medical care for a long time. Usually, I use this particular slide to just indicate how researchers are way, way behind, always racing to catch up with those innovators. But in 2023, new year, new version of this slide, I'm adding a new actor, policymakers. So recently, we've just seen a slew of innovation on this stage. Now, we might quibble about where the policymakers are on this bell curve of integration in comparison to our other actors. So maybe they're latecomers and really far behind the center of the curve. Or maybe they're closer to the early adopters. I think it depends on which state, which policy you're looking at, and where your timeline starts. But I do feel pretty confident saying that at this moment, the policymakers are somewhere in the middle, trying to develop some norms for social care. And the big question I've been asking myself is whether in that middle space, are they just too far ahead of the research on social care? Regardless, the policies feel like they're coming fast and furious. They're coming via state and federal guidelines and practices and standards and rules and regulations. Name your policy lever, and there's something related to social care. As a non-policymaker, I confess I'm not always sure how and why people are choosing to press those different levers. But as a safety net healthcare provider, I know full well people have a lot of opinions about the lever that is quality measures. So, like many of you, I took note when I heard that NCQA, CMS, and multiple states were developing measures related to social care. And at first I thought, this is amazing. Social care is being included in quality measures. And then I thought, wait a second, social care is being included in quality measures? Do we know enough to say what social care quality really looks like? So as researchers are apt to do, I turned to people who know a lot more than I do, and I started asking them questions. And some of those brilliant people who answered my calls are here with us today. That brings me to introducing them. Our panelists presented here just in alphabetical order, not in the order that they'll be talking. I'm gonna just highlight the immense expertise that we have with us today. So Emily Carrier, Senior Advisor to Manatt Health, Chris DeMars, Director of Delivery System Transformation at Oregon Health Authority, Oregon State Medicaid Agency. My dear colleague, Taressa Fraze here at UCSF in the Department of Family and Community Medicine, and Sarah Paliani, Senior Research Associate at the National Committee for Quality Assurance. So I'm going to start by asking Sarah, it's Sarah, you can actually, correct me. I thought it was the National Commission for Quality Assurance, and now I'm seeing that it says National Committee. So you can start by correcting us on that. But then second, I want to just ask all of you to orient us to several very specific social care quality measures that you know well. And Sarah, I'll turn it over to you. Both correct us on the NCQA note, and then to describe the new NCQA social care quality measure. You ready for us? I'm going to switch to your side.
I am. Thanks, Laura, and hi, everyone. It is committee, Laura, so National Committee for Quality Assurance. So there you go. Hi, everyone. My name is Sarah Paliani. I'm a Senior Research Associate at NCQA. I want to thank SHVS and SIREN for having me today, and to thank my fellow panelists. So I'm going to give a brief overview of a new measure that NCQA released recently. So NCQA published a new measure in the measurement year 2023 HEDIS volume in August of last year. HEDIS, for those unfamiliar or less familiar, is the Healthcare Effectiveness Data and Information Set. It's a set of performance measures that is used to assess health plan or health insurer quality. So this new measure is really a part of sort of broader efforts at NCQA to focus on health equity and incentivize health plan investment in social needs. So we developed this measure with guidance and input from a work group of health equity experts from plans, community organizations, vendors, policymakers, patient advocacy groups, and of course in close communication with the standards entity, the Gravity Project, which I know many are familiar with. So this new measure, called Social Needs Screening and Intervention, assesses the percent of a health plan's members who were screened at least once for each of three social needs: food, housing, and transportation. It also assesses intervention within 30 days for those who screen positive for having an unmet need. The measure assesses screening and intervention among members of all ages, excluding those who are in hospice care, enrolled in institutional special needs plans, or living in long-term care institutions. And this is a health plan measure, so the setting or accountable entity is health plans, including all product lines, Medicare, Medicaid, and commercial. The social need domains assessed in the measure include food insecurity, housing, and transportation insecurity, as I mentioned. But I'll just note that housing in this measure encompasses the subdomains of housing instability, homelessness, or housing inadequacy. So members need to be screened for at least one of those housing-related needs. The measure requires that among those who screen positive for one of those needs, an intervention is implemented within 30 days of the first positive screen. An intervention is defined as one of many possible activities that fall within 8 broad categories: assistance, assessment, coordination, counseling, education, evaluation of eligibility, provision, or referral. So this includes things like provision of medically tailored meals, assistance with application to a rental assistance program, referral to a medical legal partnership program, provision of transportation vouchers, to share a few examples. In terms of screening, the measure allows for a broad range of screening instruments, but does specify a constrained list that can be used. These are instruments which have been evaluated and determined to be appropriate for each of these domains by the Gravity Project standards committees. And there's flexibility for cultural and linguistic adaptation as needed and as allowed by tool developers. So this is a new HEDIS measure which went into effect this year. Health plans are in the process of collecting data for this measure and will report next year. As a first-year measure, we won't publicly report results on this until we've analyzed those first-year results. So it will be some time before we have initial performance results to look at and share. But we did test this measure prior to implementation and found that average screening rates for food were around 12%, around 3% for housing and transportation in the Medicaid and Medicare product lines, much lower in commercial. And intervention rates were comparably quite high, which we take as a promising signal that if the measure is successful at improving screening rates, it may result in substantially more patients being linked to needed services. So with that, I will now pass it along to Emily to talk a little bit about the social drivers measures in CMS.
Thanks so much. Hi, I'm Emily Carrier from Manatt, and I want to just echo Sarah's thanks to SHBS and SIREN for bringing us all together and to the rest of the panelists. So I'm going to talk about some measures that are either already in place or are under discussion for some programs in the fee-for-service Medicare space. And as I go, I'll try to put them into context a little bit about what we know about what states are doing, just speaking at a very high level, because there's a lot of diversity. And just a quick flag, unlike Sarah, I'm not speaking from the perspective of a measure developer or steward on any of these. We've been sort of close observers of these measures as they've gone through the process, and we closely follow what states are doing, and we've worked with some of these states in varying capacities, but not on this specific aspect of the work. And so let me just give some quick context about this measure development process generally. And this sort of harkens back to Laura's introduction about the adoption process. Prior to the very rapid sort of adoption, the progress that's been happening in the past year or so, we knew that screening was going on. We knew that there were a number of good tools that were out there, but we didn't have a huge amount of visibility into specifically which tools or which combinations of tools in various homegrown instruments were actually being used in the field. So for example, if we're looking at federal programs, we knew that the Accountable Health Communities model required screening using one very specific question set that they put a lot of resources and investment into developing. But other than that example, there weren't a lot of federal programs that required any specific approach to screening. And there were quite a number of federal programs that didn't require it to be done at all. And then looking over at state Medicaid programs, we would see that it would be very common to see a general requirement in a Medicaid contract that a managed care organization or another entity do some type of social needs screening, but we wouldn't see nearly as much in terms of requiring the use of a specific screen or a specific type of screen or a requirement to share data back with the state in any kind of standardized way. And it certainly was relatively rare to measure screening rates as part of a state Medicaid program's quality measure approach. And obviously this is all sort of very rapidly changing as we speak, but that was kind of, I would say, the general state of affairs up till pretty recently. So looking at the approach that you see in the CMS, in the fee-for-service Medicare programs that has recently come up, what they're measuring is the proportion of adult patients who are screened for 5 specific domains. And the domains are consistent with what was measured in the Accountable Health Communities program, but the measure does not require use of the Accountable Health Communities screening tool. It's very flexible. It allows for the use of any tool that covers the required domains. And there's a companion measure where the reporting entity has to report out the proportion of screened patients who screen positive for each of these domains. So if you screen, 100 patients for housing needs, and 30 of them report that they do have a housing need based on the tool that you've chosen to use, you report that 30% as well. And when these measures were sort of moving through consideration during the MAP process, this companion measure definitely generated a lot of discussion. Some providers raised concerns that they didn't really see how rates of positive screening were related to the quality of care provided. And the response that, if we were listening in, we sort of heard from the measure steward and others was that a part of the value of these measures, in addition to kind of measuring quality in the traditional sense, was that they were a vehicle for sharing information about prevalence of needs among different populations, among different parts of the communities. And the idea was that this measure was a way of doing that. But as we see, the screening measure is in use in all of the programs that we see in this box here, but the positive screen is only in one of them. And I would note that these measures are under consideration for further programs in the current MUC cycle, in the current measures under consideration cycle, but that none of that will be finalized for a couple of months. And they also indicated that the positive screening rate measure could be a building block for future measures of whether an intervention was performed based on a positive screen and whether the need identified by that initial positive screen was resolved. And in fact, if you look at the next slide, we can see that 2 measures that are looking at these comments are actually under discussion as part of the MAP process this year on a similar timeline. And again, they will look at, so that addresses kind of, if we can go to the next slide, that addresses kind of the concept of intervention that is somewhat parallel to what the measure that Sarah just described, but it would do it in a different way. And of course, all of, these are in the very early phases of consideration, and a lot of changes could happen if they become incorporated into measure sets. So it's worth noting that these measures do apply to all adult patients, not just Medicare enrollees. So in theory, they could capture data on Medicaid populations as well, but the age criteria and the 18+ criterion would be a pretty important restriction in terms of their ability to shed light on what's happening in Medicaid. And thinking about sort of how the federal approach relates to what states are doing, it doesn't follow any specific state's approach, but we can see different sort of aspects in what different states are doing. So I just wanted to sort of very quickly mention 2 examples. North Carolina's Medicaid program requires use of a specific tool that's similar to, but not identical to the AHC tool, the Accountable Health Communities tool, and it asks its plans to screen. And so there we see that consistency in like a very sort of broad-based population-wide screening approach that uses similar domains to what CMS requires. And in contrast, Massachusetts has in the past, and I'll just say again, this is sort of a very fast-moving space, so things are changing all the time. They have had a measure that has been restricted to just their ACOs, but that doesn't require a specific instrument as long as it's an approved instrument that includes certain domains that overlap with what CMS is asking for: housing, food, utilities, transportation. So we see that neither of these approaches is identical to what CMS is doing in this measure, but they could both kind of be folded into it given its flexibility. And I think I'm gonna pass over to Chris and we'll hear more about sort of the thinking that states are putting into this. Thank you.
Thank you. So hi, everyone. Once again, my name is Chris DeMars. I'm the Director of Delivery System Innovation at the Oregon Health Authority, and I'll give some detailed explanation on a state developed measure. In Oregon, we developed a health-related social needs screening measure for entities that we call coordinated care organizations, which are kind of ACO-like entities that deliver care to our Medicaid population. Oregon's using a phased-in approach, or kind of a glide path, which has the CCOs assessing capacity during the first year, followed by building out kind of screening in years 2 and 3. So specifically, starting in 2023, just this month, both the CCOs are working, expected to work with community-based organizations, and OHA, Oregon Health Authority, where I work, is also assisting with this to help build capacity for referrals and meeting social needs. And so I'm talking about things such as preparing for equitable, trauma-informed, and culturally responsive screening and referrals, supporting the CCOs are going to be responsible for developing systems to support data sharing between them, providers, their contracted providers, and community-based organizations. And essentially, one of the kind of main overriding reasons for developing this glide path is that it's so important to support establishing the relationship building between the CCOs and their partners, their community-based organizations. And this is a huge culture shift that we know takes time for those relationships to be built. So this kind of first phase, as I mentioned, starting this year, and it's a three-year process of this kind of building the capacity. That kind of overlaying that is starting year 2. So next year, we're going to be launching, the CCOs will launch, OHA will launch into assessing the screening, actually, and CCOs will start launching into screening, and they will report on a sample of their members on screening. And then starting after that in year 3 and beyond, we'll be reporting on their full population. Other kind of characteristics of this is as I kind of alluded to, but it's the ages, it's all any age, so all CCO members. The domains are 3 domains: food insecurity, housing instability, and transportation needs. The intervention is screening and referral, but there is not a requirement for a closed loop referral. And then in terms of the screening tools, there's flexibility with regard to the tools that are used, but they need to be approved by the Oregon Health Authority. So tools such as the Accountable Health Communities tool that was mentioned before is one of the tools that will be approved. So that's an overview of Oregon's approach, and I'm going to pass it back to Laura.
Thank you all for doing this landscaping for us. We've, in working with Sarah, Chris, and Emily, we synthesized the measures that they just described in this kind of quick glance summary table here on this slide. And again, these slides will be available to folks following the webinar who want to refer back to these. But now I'm going to turn things over to Taressa Fraze to do something just a little bit different. So beginning in 2020, Taressa and our team at SIREN were supported by State Health and Value Strategies and the Robert Wood Johnson Foundation to talk with leaders from 14 different state Medicaid agencies, including Chris, all of whom are thinking actively about accountability for social care, but in ways not limited to quality measures. So Taressa got a bird's eye view that's even higher up than this table bird's eye view that's on this slide. And I invited Taressa to share some of the big takeaways from that research. So Taressa, over to you.
Great, thanks, Laura. And so as Laura mentioned, we were really kind of inspired knowing that there were many quality metrics kind of coming down the pipeline, and we wanted to get a better understanding about how state Medicaid agencies were thinking about that accountability. So the first thing that we heard was just really about being pragmatic. And this was a theme that kind of cut across all of the interviews and in every line of thinking. So they first thought about, what buttons or pressure points do we have? What existing mechanisms can we leverage? This might look like leveraging an upcoming procurement process. It could be revamping some quality improvement projects that are already included in current contracts to revamp those towards social determinants of health. And then those projects would, of course, have built-in milestones and processes to ensure accountability. But across the board, we really heard leaders being pragmatic, strategic, and just really incredibly savvy about moving what they can, when they can, where they can. Next slide. And the next thing that we really heard about was kind of this notion of like scaffolding and really strategically increasing accountability over time. And Chris talked about it as a glide path, so very similar to that. They helped managed care organizations and providers scaffold their efforts, usually over multiple years and multiple contract cycles. So for example, as Chris mentioned in quality metrics, this might look like starting with pay for reporting, and then in the next year, building in more incentives, and then finally adding in stronger penalties over time. In terms of the quality improvement projects that we heard folks doing a lot with, in the first year, they might just say, hey, managed care organization, just do something related to social determinants of health and tell us what you did. So let's just, get your head in this game and get some acceptance that this is where we're going. And then in the next year, they might start giving greater guidance on what that project should look like, adding in more rigorous milestones. And then finally, we did hear, states starting to talk about like, how do we tie payment into, if you said that you're going to do this project and here's what your goal and your target is for this, are you meeting that target? And then starting to give payments based on that. But the idea then is just that they really emphasize the importance of getting folks started and comfortable with assuming, with assuming responsibility for social determinants of health. And one of the things that really struck me was that they felt like they were on a journey, both in community and in partnership with the managed care organizations and with their providers who were implementing things. And then finally, leaders were incredibly aware that this is a delicate balance on multiple levels. And, so first, they recognize that this is it's hard. This is really hard work. It's hard for managed care organizations and providers to assume responsibility for this. This is new work for them. And there can be some challenges associated with just starting to accept it, that this is indeed in your lane and that you are going to be held accountable for that. And so in recognizing that hardness, they really empathize with the managed care organizations and the providers. They empathize that these folks are already doing a lot, right? That they're adding in another egg to this already incredibly delicate stack, and they're not taking away anything else while they're adding something in. And so that's part of the reason why they wanted to do the scaffolding, right? To build that in over time, because they are adding in additional responsibilities onto folks who already have a lot of responsibilities. And then of course, new things are especially hard when we aren't sure what the best thing to do is, right? So we heard in the NCQA measure that, we're going to start measuring, like, are they receiving an intervention? Well, what intervention? And so we heard state Medicaid leaders really saying, well, we're not completely sure like what the best intervention is, right? So we want to kind of tinker around and get folks starting doing something, see what's going to work well for our enrollees, for our members, for our population, what interventions might be good for them. And so when you're starting something that's new, that's scary, that's hard, you already have an exceedingly full plate, and you're not even sure what you should be doing, they were just aware that was an incredibly delicate balance. And then they were also aware that this is really hard internally as well, right? And so if they didn't anticipate it, and I think most of them did, they certainly experienced very quickly on the ground that this was a huge resource intensive activity for the states as well. And they emphasized that, as they're thinking about how this work is done in partnership and in community with the managed care organizations and the providers, that meant they had to do their part as well, right? So in some cases, it may be as simple as purchasing shared resources that all the plans needed or that providers could use. And so kind of pulling together resources and helping to coordinate that. But really what struck me was just all of the management work, the hand-holding, the coaching, the mentoring, the task manager, moving things along, really dedicating bodies and resources to help invest in this and invest in the plans being successful. And then, so really just the awareness of the challenges faced both internally and externally really shaped how they approached accountability. It shaped how tightly they held MCOs and the plans that they put in place to improve social determinants of health. It impacted how they structured that glide path and how they scaffolded accountability. All right, Laura, I'll hand it back to you.
Thank you so much, Taressa, for that setup. As I mentioned earlier, we are going to now shift to just a discussion. There's already an active Q&A. I have my own list of questions, which I think touches on some of the great questions that are coming in the Q&A. For panelists, if you are so moved to answer some very detailed questions about some of the specific measures through the Q&A function, please go ahead. Or to the State Health and Value Strategies group, please feel free to do that. I'm going to stop the share at this point, but remind everybody that the slides and a recording of the presentation will be available following the webinar. So if you missed something, do not stress about it, or if you missed a screenshot during the presentation. Okay, so I'm going to stop the share, ask all the panelists to just turn their videos back on. Emily and Taressa would love to see you if you can. And let's do this. So I was really struck, Taressa, by the language that I've been thinking a lot about in the quality measures specifically that you use to refer to just what states are doing across the board, not just in the quality measure space, about the difference that kind of shines through in that in even that summary slide, the summary table about the different quality measures we're talking about today, is some groups are saying do something, just do something, almost anything. And some states are saying do something specific. We want you to screen in this way. We want you to include this kind of, not just states, but some of the measures are including like much more detail, like the Joint Commission, which is, you know, not a quality measure, but a new standard for hospitals, has said we want you to follow up with a referral to a community agency. And NCQA has said, act on it in some way, like one of these many different ways. And that difference is actually really striking. And so I'm going to turn to the panelists, and I am going to start by saying, why is there so much variation in the measures that we are looking at today? We're seeing it again in what domains are covered, what measures are used, or what instruments are used to measure those domains, and is an intervention required, and what kind of intervention is involved? Why is there so much variation? Who wants to go first?
I'm happy to share some thoughts on this, Laura. So I think maybe part of the reason why we see a lot of variation here is that there have not been any concrete standards in this space really until recently. And so maybe we're in sort of a calibration period, or we're in a period where we're seeing a calibration happen, and hopefully with time we'll see a little bit more uniformity. That's certainly a hope and a commitment that NCQA has as we, see all of these measures come out into the ecosystem. I think there's variation we're seeing in a few different areas. You highlighted a number of them: the domains, the instrument requirements, the inclusion or sort of definition of how follow-up or intervention is specified. I'd also probably add inclusion of a screen positive rate as an area of variation or difference we're seeing between measures. I can speak a little bit to why NCQA prioritized certain decisions on a couple of those fronts. With regards to the domains covered in our measure, we really looked to see where there was sort of a convergence of importance to outcomes, policy prioritization, and availability of data standards. And we sort of ultimately landed on food, housing, and transportation as a convergence of those criteria. But again, the criteria that all of these various entities are using to make those decisions might be a little bit different. I think with regards to the requirements for specific screening instruments, we felt it was important to have some level of standardization or sort of a way of knowing that we're measuring the same thing in an appropriate, valid way, while also allowing for flexibility and acknowledging the wide range of tools that many organizations have had in use for quite a long time. So we landed on alignment with an existing standard, the Gravity Project, and sort of allowing any one of those instruments evaluated by Gravity for those domains.
Anyone else?
Yeah, I'll just mention, it's important for us to, say out loud the broader context for this work, which is the, huge societal conversation that's been happening around health equity and the role that these drivers of health play in health equity. So any quality measure is a series of trade-offs. They're all an attempt to capture this sort of amorphous thing that we know and we see called good healthcare and pin it down and describe it in a series of very clear sentences that everyone can apply. And that always involves, different distortions and trade-offs and choices. And this measure, these measures are, I think what's distinct about them is they're happening, as Sarah talked about, maybe in an earlier stage than they might have happened in some other clinical areas, but in the setting of a very strong feeling from a number of stakeholders that the trade-off of not measuring right now, of waiting until the field has further evolved, was not something that was acceptable to them.
So you're begging another question that I know is actually of interest to you, and you and I have talked about it. So I'm going to actually just stick with you for a minute here, Emily, which is, what are the implications of starting down this road? Because we think that the balance, as you just mentioned, is it's more important to do something than to have it exactly right. What are the potential negative consequences of getting it wrong out of the gate, and refining over time? But like, what could go wrong here?
Well, this is, and I would say this is true of any measure. You know, there's a famous saying, Goodhart's law. When a measure becomes a target, it ceases to be a good measure. And for, you know, inevitably every measure becomes a target to some degree or other. So everything that's put in place in a quality measure is something that reporting entities orient to, you know, in a very kind of detail-oriented way. If you tell them to do A, B, and C, they'll do A, B, and C. And then, you know, given the, you know, the size and scope and complexity of our healthcare system, other entities sort of spring up around them to support them in that work. The specifications, the details of these measures will feed EHR design. They'll feed the development of these sort of like various platforms that are used to document social needs screening and intervention. They'll drive provider workflows and decisions about who to hire in the kind of supporting roles that do a lot of the important screening and intervention work. So there's a lot of path dependence in your initial specification. And it's not necessarily a bad thing to be setting off in one of these directions, given, you know, the importance of going to see it all. But it is important to understand, like you said, that course correction might be necessary, and that it is a big effort to kind of bend some of these initial paths that people are starting to follow when you learn more and develop more evidence about which is the best point on which you want everyone to converge.
Yeah. I'm going to change tack because a lot of the questions that are coming up in the Q&A, my guess is we're going to get back to some of the sort of big overarching implications questions that you just triggered for me. But I do want to make sure that we address some of the questions that are coming up here, which are so many good questions. Keep them coming. Clearly, we're not going to get to all the 46 even that are there so far, but they seem to cluster a little bit. And some of them are about the design and development stuff that Sarah was just talking about. I really appreciate this question about, Chris, during your presentation, you talked about culturally appropriate and you know, culturally competent measures. I can't remember the term that you used, but somebody asked about it. And I think that it's relevant to this issue of, like, you know, Emily brought up this overarching thing. The assumption is that these are going to advance our progress towards health equity generally and racial health equity specifically in the healthcare sector. What are we doing in these measures to make sure that we are not further marginalizing marginalized populations? And I'd love to hear a little bit about Oregon's process in that way.
Yeah, the term I'd use is culturally responsive approach and trauma informed and not exacerbating trauma, right? And so through the process, and I think that's what you're asking about. I mean, that's how I'm hearing you ask the question. And some of the, I mean, this is brand new, right, in Oregon, but some of the ways we're hoping that the measure could be rolled out, the screening could be rolled out in a culturally responsive way, are the provider perhaps using motivational interviewing as a part of the screening process. Obviously, you know, screening within the language of the member, of course. Hiring maybe practices having a community health worker on staff who could actually conduct the screening as well would be culturally responsive and could be more trauma informed. So those are some of the approaches that we're thinking of, and I'd be, you know, love to hear if others on the panel have ideas of how to do this well.
Sarah, Emily, in the experiences that you've had working with, you know, or seeing, in Emily's case, the process unfold, either in different states or at NCQA, have those same kinds of topics come up, and how have they been built into the existing measures to make sure that there's some accountability for doing this work in a way that is culturally responsive and trauma informed, or at least that we're looking at how having some accountability for this improving care.
I would say from where I've seen, which has been, which is certainly not encyclopedic, that aspect of the screening, the cultural responsiveness, has really been more part of a broader discussion about how you can get a workforce who has the lived experience and the understanding to deliver a broad range of services in a culturally competent, conversant way. And I haven't heard discussions necessarily restricted to this screening task. Again, my visibility isn't total by any means, but I've much more heard in a broader sense of how do we identify people to do a wide range of screens in the right way for the people that we're serving.
Sarah, do you want to weigh in on that?
Sure. Yeah, I'll just say that, at NCQA, we sort of think about a number of different accountability levers, and measurement is one of them, but we also have, standards and recognition programs. And so sort of a parallel effort to this measure and sort of other health equity focused measurement initiatives is our health equity accreditation standards. And I think those standards are sort of a parallel and partner piece of this that really look at and think about the implementation of all of these efforts, screening and such, and really get at some of the cultural competence and cultural considerations around implementing screening.
So let's take this just to the next step, which is, how are we going to know in the end if these measures are actually making a meaningful difference in health and health equity? Which I think, several people have asked questions about accountability for actual outcomes that matter to patients. Taressa, I know you have had some thoughts about this, and I think it relates even to some of the aspects of your presentation, but can you weigh in on that specific question? How are we going to know? Is this some of these are structural measures, pieces of the CMS measures anyway are structural measures, some of these are process measures. Where are the health outcomes? How do we get to the measures that really show that we're making a difference?
Yeah, I mean, I think that's a great question. And I think that it has to be kind of part of that glide path, right? And that I think the question speaks to where we're at in our scaffolding. These are new quality metrics, which, as you started this discussion off, is why there's so much variation. Do we think that this screening alone is probably going to have a huge impact in moving social determinants of health? I think that it's fair to be a little skeptical, but I also think that it's important to start. Right. And so if we can just keep in mind that picture of what our scaffold looks like and where we want to be going, we have to start somewhere in there. And so I think that as we evolve and as we move forward, we'll find ways to build in greater accountability and to start to move the pieces that are really important. But I think what we're seeing now is just kind of is step one, and we can all be part of the process of defining what step two should be, to making sure that as we identify needs, that we have really robust processes to move the needle on those.
Thanks, Taressa. So let's go back to some of the implementation questions that keep appearing in my chat. And I see that the Q&A, I can't tell if everybody else can see all the Q&A, like all the participants can. I'm so sorry, I haven't. State Health and Value Strategies, feel free to weigh in on that. But it sounds like some people can only see some and some people can see all of them. So I'm not sure, but I'm going to do my best to bring all of the questions in some way. There are a number of questions about implementation and what is needed to actually put these into place. So, what are the technology systems? What are the codes? Where are you pulling them from? Somebody wrote about VSACs. I don't know if our whole audience knows about VSACs. I didn't until relatively recently. Sarah, can you talk a little bit about what NCQA is picturing people are going to need in order to act on the NCQA measure very concretely? Tech, interoperability, coding stuff, workforce, what are the things that you guys have been anticipating are going to need to be in place?
Sure. So I think certainly from an implementation perspective, there's a technology infrastructure that will need to be in place and sort of evolve over time. Health IT systems are going to be what's enabling tracking of screening results, linkage to care, ultimately helping to track sort of outcomes of referrals and interventions. As a part of that, or sort of enabling that, I think is standardized terminology that will enable interoperable information exchange. And thanks to the Gravity Project, I know there have been a number of questions about what the Gravity Project is in the Q&A. Gravity Project is a multi-stakeholder public consensus body that has developed data standards and terminology for documentation of SDOH data in healthcare. So we do have sort of a great starting point as far as that standardized terminology goes as a result of Gravity's efforts. But I definitely think, health IT infrastructure and advancements in information exchange between the health system and the community will be needed, along with that standardized terminology.
Emily, I know that you have done some thinking about, well, implementation for whom? Like, some of these are for plans and some of these are for delivery systems, and maybe there's some differences in the implementation needs across those two different groups, which I feel like you have a very clear appreciation for. Do you want to build on some of the comments that Sarah just mentioned?
Yeah, sure. I mean, I think that's, those are the key points. And I often think think about this in the state setting. The federal programs that I spoke about earlier have dedicated reporting portals, which addresses some important needs. If you're a state thinking about this, for example, for your Medicaid program, you need to figure out what kind of data you want to pull in. Do you want to use the code, do you want to use the low-end codes? Do you want to use Z codes, which I know there's been a lot of discussion of in the chat? Do you feel like you need to even go back a step earlier and have some sort of, kind of customized reporting tool because you're not sure you have a clear path for those other two types of data to flow? There's all these technical solutions that you need to have just to get the information from provider to state, potentially via plan or via HIE or via data, some other kind of APCD or some other, data pool. And then you need to have, some sense, the stakeholder relationships, the community relationships to know that you're capturing the right things and to be able to analyze and understand the data once you've ingested it. Because you may come back with this series of screening rates, and if you're choosing to measure it this way, this series of positive screen rates. And then it's really important to ask what you're going to do with it, how you're going to understand it, and then very importantly, how will people see real change, I think, to what you were just talking about, coming out of this process. Understanding that maybe resolving everyone's social needs may be something in the more distant future of these programs, but at least having the providers who are doing the work feel like something happened as a result of that screening activity. We've heard a number of folks say is very important in keeping people engaged in this, both providers and the beneficiaries of the enrollees who they're serving, helping them to feel like this sort of interaction that they've had, which can be time consuming, it can be draining, it can be challenging, is really important and is helping people get what they need.
Great answer. Chris, lest you think you're off the hook, one of the really interesting things that, a number of people have commented about how great it sounds like, people are really appreciating the Oregon process. But I am struck by how you launched this process before you knew all this stuff was going to happen at the federal level, whether from federal agencies or from NCQA and other accreditation bodies. So, I'm going to ask you, would you have gone through this process? Would you elect to go through all these cool things that you did with bringing in, lots of different stakeholders and getting lots of input on the path forward if you had known that this national stuff was going to come down the pike? And what advantages, how did that position you as a state to be ready for the, all the national things that are happening now? I think, that we have a lot of state audience people on this call today, so I'm sure that people will enjoy hearing your perspective on that.
Yeah, that's a great question. I would say that most likely we wouldn't have gone through the multi-year process, which if we had more time, I could go into the detail, but we do have a report on our website that that talks about that. And I'm happy to put it in the chat, but I mean, this was a, 3-year process, just developing the measure. And then actually the discussion about it started, quite frankly, in 2015, talking about doing a food insecurity screening metric, which kind of, moved to something broader. So I would say it was a lot of staff time and a lot of effort. And so if we had known that there was going to be a measure that was, kind of a measure, something available this soon, we may not have gone down this road. However, I would also say that we benefited quite a bit from going through this process. We were able to really design a measure that is kind of fits within the Oregon kind of structure and system. There was a lot of screening happening kind of at clinics across the state already. And so that's, for example, one of the reasons we designed the measure to be so flexible, to meet practices where they already were. We engaged in quite a bit of kind of public input from some of the Oregon Health Authority staffed committees, such as we have a health equity committee, we have a Medicaid advisory committee, to get their input on how to design a measure to make it as trauma informed and as possible, and received wonderful input through that process. Make sure that some of the highlights we got from that are make sure that it was designed with a real patient-centered approach. And there were concerns about screening without follow-up. So at least try to build in the referral piece. Don't just screen, down the referral piece. And the information that we gathered through this really robust process is informing what we're putting in place right now, which is a pretty comprehensive technical assistance approach for our coordinated care organizations and for providers and community-based organizations as well. We have an office called the Transformation Center, which sits within the delivery system innovation area that I oversee. And I think this multi-year process gave us the information to allow us to provide really helpful TA. So that's I think the bright side of going through this process is and the last thing I'll say is, and what it did is it allowed us to kind of socialize that this measure was coming, so that the CCOs weren't just kind of, one day, oh, okay, there's this new requirement for us. Oh my gosh, how are we? Because it's a huge culture shift, right? I mentioned that already, having the kind of traditional, Medicaid managed care organization, the traditional healthcare system work in partnership with the community-based organizations and the social service system is something that takes time to build up. And that's why we have the glide path in place. And that's why I think it was good that they've had a number of years getting a sense that this is coming and I'm needing to get ready for it.
Yeah. And Taressa, I'm imagining that you saw that similarly in a lot of the work that you did. You described a little bit of it, but like this idea that there is a benefit to the glide path, to the, states doing all this background work, even in the context of some of the national work. Do you want to comment on that at all?
Yeah, I mean, I think that there's definitely a benefit to doing it. And quite frankly, not everyone can be quite the earliest of the early adopters that Chris and her team was, right? So, I mean, I think that folks they thought about like, okay, what can we do? What can we do on the time frame that we're trying to move something? And they saw what incredibly hard work it would be to develop the big formal quality metrics and getting buy-in for that. And I think that that's part of the reason why so many of the states that we talked with started at other places. It wasn't that they didn't want to get the quality metrics. It was that they wanted to build off the work that hopefully the feds were going to come in and do, and folks like NCQA and the Oregons and the Chris's. But I think that having that work go on, the things that they were doing in the context of all of these other pieces is incredibly useful, especially as so many of the states we talked to were focused on figuring out how to intervene on their patient populations. Now they have, a laundry list of things that they think meaningfully can improve their enrollees' lives. And now they're going to be able to start to think about how to scale that and how to measure that in the context of what the federal entities are doing.
Thanks, Teresa. Chris, there are people who are saying, we want that link from the Oregon work. So definitely pop that in into the chat if you can before we close out. I will say that there have been a number of comments that I will cluster into a group that I think all of us have been concerned about whether or not more activity in the healthcare space is really going to lead to a shift of resources to the social services and community-based organizations that actually are really responsive to patients' social needs and are much more community-based. Instead of setting that up as a question for you, I'm actually going to use it as a closing, which is I feel like what we have now is this remarkable national laboratory that is kind of coming in the shape of, all these different measures kind of being pushed out at the same time. And it is incumbent on all of us to use that laboratory to really figure out what works and for whom and why, and then to refine the measures over time to ensure that they're leading to improved health and improved health equity. So I really, really appreciate the comments that you all have made, both in your presentations and in response to my, crazy questions. And hopefully I've done justice to some of the questions that came in the Q&A. I'm sorry we couldn't get to everything. I know all of our panelists are really very available and responsive on email. I happen to know because I email them every day. And I would welcome you to send us more questions or to ask for more information or resources whenever you need them. Heather, I am going to turn it over to you, but not without one last shout out to our panelists and to State Health and Value Strategies and to our SIREN team for making today's event possible, and certainly to all of the participants for joining us and for asking great questions and being interested in this space. Heather.
Thank you, thank you, thank you. Laura, that was amazing. Thank you for facilitating such a thoughtful discussion. And I think that incredible engagement with the questions is really a testament to the deep interest in the issue, and also reflects on sort of how compelling you and your fellow panelists' presentations were. So thank you on behalf of SHVS. Thank you to Laura, the team at SIREN, and all the presenters. We've got here Laura and my contact info, but I know, as Laura just said, that everybody is really committed to these issues and would love to hear from you. So we learned a lot. We had tremendous engagement, Laura, right? We learned a lot, and even the questions we didn't get to, we're going to noodle on, and it will help inform programming in both of our respective shops. So this was so valuable. So thank you again to everyone who participated, and reminder that this will be posted, so you'll be able to go back and you'll be able to access both the slides and the recording. So feel free to share it with colleagues, and thank you again, and watch both of the SHVS and SIREN spaces for more programming in this area. So thank you, everyone.